It's a pleasure for me really to be here. I've had the most amazing 10 days here so far, and we worked with Klaus to think about what type of presentation could best work for this purpose. So all the responsibility for all that is bad is mine, and if there's any good bit is in interaction. I mean, shape thinking how this could work. I will give you. So the idea for this presentation is basically, some of you may find at the beginning a bit reiterative in the sense of concepts that you probably you know inside out, but I think it's useful because we are thinking the presentation aims to respond how AI can support primary healthcare, primary care, family medicine, and then also shift slightly the focus to patient-centeredness and different ways in which it's operationalized and measured, and how AI can change that too. And then it will go back again to focus on a more general perspective of how AI can change health systems. We can see AI changing health systems in the coming years, possibly months. Very happy to have, if you at any point want to interrupt me, just do. And if not, very happy to take questions afterwards. So straight into this. So three concepts, no? Family medicine, the unique medical specialty in three characteristics that shape its scope. And they are, we were having a brief conversation before the seminar too, when it was about, reclaiming the notion of generalism. I completely agree, but I think it's not just as we are generalists, we are unique in three particular ways compared to any other medical specialty. We will focus on the whole person, whereas other specialties tend to focus on specific aspects of the individual. Note that whole person is not necessarily the same as person-centeredness. It was one of my I was involved in the Astana Declaration and related work in relation to the vision for the 21st century, and somehow patient-centeredness made its way into the declaration. It's not that I'm not saying that family medicine should be not patient-centered, but I would expect also my hepatologist to be patient-centered, and also any other specialist. So it's a different thing to be whole person oriented and to be patient-centric. Then life course. I mean, most of the other specialties focus are episodic, or they can be chronic, but they are certainly not life course as we are. From delivery, prenatal care to end-of-life care. And that makes it unique. And note that all these different dimensions are unique in themselves, would more than justify, could be the linchpin on which to use to shape the scope of our specialty of family medicine. The last one is that we are embedded in the community, and other specialists, can also have a role in the community, but the specialty is over encompassing, whereas it is part of the nature of family medicine to be rooted in the community. There's a 3.5, or if you want, a fourth one that I have not added, of which I've been perhaps more aware. More recently, 5 years ago, I moved from the UK to Singapore. I was a general practitioner then. I had been trained as a family physician and family and community medicine specialist in Spain. I moved to the UK, then I was a general practitioner. And then I went back to being a family physician in Singapore. Just by name, all these things, exactly the same, more or less the same scope of work. And it made me reflect more about family and how much we are not, how we've been narrowing the scope of the, from the group, from the community, or even not just even the family to the individual. Particularly in Western medicine, it is more and more about seeing individuals in the community. That's basically in a nutshell what family physicians do. And I think that's something that is also part of the DNA that we would like to revisit. Okay, primary care. Some of the signs here are for primary health care or primary care. So again, apologies. I'm not trying to lecture anybody at all. I'm just bringing a few concepts, and this is how I will use them. But then you, when we leave the room, or even as soon as I finish, we can use any other consensus on this concept. So primary care sits between the population and specialized care. Is a significant part of very specific parts of the health system with very specific functions. So one is the first contact, or should be, facilitating the entry gate to the health system. Once patients are in primary care, we can be supported in interacting with other parts of the system through our coordination, and the degree and the intensity of that coordination that may be needed may be dependent on the comprehensiveness of primary care itself. How much, primary care needs to be able to provide a response of sorts to any problem. And sometimes the response is, sorry, this is not something we can help you with, but there's somebody else that will. And at the other end of that spectrum is something that primary care can be completely responsible for and does not need support from others. So that would be the comprehensiveness. And of course, then the continuity. And although I need to acknowledge a bias, I don't think that there are plenty of definitions of continuity, and some of the taxonomies have been strenuously trying to identify every possible angle. I think that continuity is relational. I think that's at its core. That's what is. So it's the unique bond between an individual or possibly a team that remains to be seen, and with an individual practitioner or a team and an individual person in the role of patient. But you have also here on the slide continuity between primary care and specialized care in terms of managerial continuity, in terms of informational continuity, ensuring that across the board there are those aspects of continuity, which certainly useful, but I think these are just efforts to try to demonstrate that the field has been scoped thoroughly, but yeah, I have my biases in relation to the concept. Third, primary healthcare in its last incarnation from the 1978 Declaration of Alma-Ata. So everything that happened afterwards, including the 2008 WHO report, primary care now more than ever. This is what the WHO tried to distill the essence of primary care. I cannot. Every time I show this, I feel, because I remember distinctly the room in New York in which UNICEF and WHO and others, and everybody very much like I was now making an effort to try to clarify family medicine, primary care, now primary health care. There were so many implicit assumptions, and at some point we said, okay, enough. And we've been talking for months, and then we put the chart and we did something like this that eventually became a much nicer figure. So basically, what is primary healthcare? The logic is a bit of Russian dolls, but not completely, because family medicine is a specialty, is a medical specialty. Primary care is a part of the system, and so it's not that family medicine sits necessarily maybe people may want to turn their microphones off. Thank you. Hear themselves. Thank you. And primary healthcare is an orientation of the system, no? And so the three characteristics, and perhaps building upon the immediately previous one, is the primary care and essential public health functions at the core of integrated health services. Basically, an emphasis on those aspects of the health system that are in closest contact with the largest segments of the population. Then multi-sectorial policy and action, health for all, and so on, and empowered people and communities. And that has to do with people-centered care and patient-centered care, and we will touch upon this later. So this was simply to revisit these three core concepts that we will be getting back to. When we think in terms of what a health system does, there have been a number of iterations and versions and people coming from different angles. But the triple aim by the Institute for Health Improvement, probably because of numerology, and 3 is a very catchy name, is the one that has gained more structure, but it's reasonably intuitive. So we certainly have health systems to improve the health of the populations. We also want to do it in a way that is that there is a financial aspect to it. This is perhaps the one that has, of the 3 sides of the triangle, is the one that has seen the biggest variation. So sometimes it's sustainability of the health system, other times is actually affordability of the system, so more for a patient-centric perspective. So some financial aspects of it, improving population health, doing things properly from a financial aspect, and also ensuring that that the care that is provided is consistent with, reasonably consistent with the expectations of people. That's what patient experience is. Subsequent iterations had added a 4th and a 5th, and because I'm strongly opinionated about anything, I would be also opinionated about this. So I'm not quite sure that the 4th aim, which is workforce experience, I think it's something that we absolutely need to take into consideration. I am part of the workforce, so please take my opinion into consideration. But I don't think that's why we have a system. It's part of the things that we take into consideration. Similarly, equity. I understand why there's out as a 5th, but I think it comes from the assumption somehow that it would not be represented here, and I think it is. I mean, equity is a dimension of all of them, so that you would have not just improved population health for a segment or on average. I mean, you also focus on the distribution and ensuring that it's equitably addressed, similar for the others. So I think that the 3 versions do a reasonably good job. So why, you may be wondering, something has changed? What has changed? Okay, these 2. Because we're trying to think in terms of how to approach how the system operates from a patient-centric perspective in terms of the health outcomes. You can, perhaps what people think about these issues are one of the most straightforward approaches to ensuring that there is responsiveness, that in the measurement. I mean, that we measure the performance of the system as seen through the people through the eyes of the people who use it. So patient-reported outcome measures would be one of the instruments, the tools that we have at hand. Patient experience very frequently is actually measured using patient-reported experience measures and other ways that we will also tap on soon. And also the financial aspect is what is sometimes, has given rise to the notion of value-based care, which some people, have also a bit of a organic reaction, and maybe they are right, thinking that there is a way of selling cost containment, and but at its heart, or as originally conceived, is basically ensuring that we don't provide services that do not result in added value to the individual, and that would include, of course, a financial aspect. So I will spend some time on PROMs. What are PROMs? Why we want to use them? Does it really matter, and how they've been implemented? There are a few, I didn't mention some of the affiliations here. I'm the head of the Department of Family Medicine, a National University Health System in Singapore, but I'm also the director of CRISP, the Center for Research in Health Systems Performance. And some of the work that we do are also under that umbrella. So what are PROMs? PROMs are patient-reported outcome measures. So these are any aspect of the health of an individual that is reported directly from the patient, is elicited directly from the patient, without anybody mediating that. Of course, in some circumstances in which you may have, for instance, people who may not be able to communicate for different reasons in the way you expect, or that would be necessary for the measurement, you can use proxies. That's a different matter, but the essence of a PROM is that it's something that comes from, it's not the provider who is giving a rating, it's not an objective measurement, let's say in the form of an imaging or a blood test. And how they typically constructed? You have a stimulus, in this case, typically an item. This is taken from the SF-36. How much bodily pain have you had during the past 2 weeks? A response scale, which can be, either the so-called Likert scale, which is a graded scale, known very mild, moderate, severe, very severe, or sometimes a visual analog scale. And then a scoring system that basically combines the scores for all the different responses into a score for an individual. And there are a number of ways in which scores can be constructed by summarizing different domains, having weights, depending either elicited from patients or elicited from professionals or the population, etc. This is an example of a patient report outcome measure. This is the WHO 5 Wellbeing Index, and it measures psychological well-being, and you will see it again later during the presentation. I'll just read for your benefit the 5 items. Please respond to each item by marking 1 box per row regarding how you felt in the last 2 weeks. I have felt cheerful, in good spirits, all of the time, most of the time, more than half of the time, less than half of the time, some of the time, at no time. And with similar response options, I have felt calm and relaxed. I felt active and vigorous. I woke up feeling fresh and rested, and my daily life has been filled with things that interest me. These metrics, when people see that and they compare this with machines that go beep, they are very underwhelmed and underimpressed. The metric properties of these tools are exceedingly strong. They, and perhaps more importantly, there is no substitute. When you try to correlate individual metrics, such metrics, with other tools, let's say, for instance, in terms of, let's imagine you're focusing on symptoms, and then you focus on, let's say, your function, respiratory function. When you try to go as close as it gets, at most you get a correlation of 0.3. But it's very clear that you get information that you cannot elicit elsewhere. And also in terms of reliability, validity, sensitivity to change, the evidence is there for how strong the metrics are. If you think for this in terms of cough, many of the measurements that you are familiar with did not, the effort that psychometricians put in seeing all these instruments from different angles and ensuring that they are robust is quite something. I'm very often in rooms with clinicians that do not really have absolutely no idea what are the metric properties of the machines that go beep or the measurements in blood. But they are very comfortable challenging whether that's a good metric or not. And there is a good paper in the Mayo Clinic proceedings evidencing that they are completely on par. So what do they measure? So this is an attempt that we did to what do patient-reported outcome measures measure? You may have seen PROs, that's more typically from the US. PROMs, actually more from the UK. More on that in a second. But I remember I was with John Ware at the University of Washington. He's a very distinguished professor of quality of life research, has published a ton, and he was challenging in my presentation. I was saying that it was a bit tomato, the use of the words, and when he was making a point, it wasn't. In the end, I mean, if you look at the most accepted definition, is actually that a PRO is a measurement. So it's to a degree a measure, but okay. What I want to get at is that it's mostly the reason why we used to call them now PROMs is because the UK invested a lot of money in being the first to try to use it for benchmarking performance of their hospitals for elective surgery. They try to do it for cataracts, for hernia, for inguinal hernia, and then hip and knee replacement. The first two didn't work for a number of reasons, and then mostly with elective surgery. And because they use the word, the acronym PROMs, and because that was the first nationwide effort to have those metrics benchmarking. That's why it's stuck now in the literature. But if you read the American literature, it's still PROs. So what are these PROs? This was an attempt we did to try to combine the International Classification of Functioning by the WHO with the Wilson and Cleary model published in JAMA 1996, which identified different constructs that define PROs. And it was indeed a matter again of potato, because you can see in the paper, these are different words, but the concepts are, so starting through with biological and physiological variables, they have an impact on symptom status, which are the first ones that you can actually measure, self-reported symptoms. So that would be what aspects of your perceptions of your own body are you're able to appraise. That would be the symptom status, which has an impact on functional status, so what you can and cannot do in real life circumstances. And then that has also an impact on so-called general health perceptions. The notion that you have your perception, your own perception of what, how are you doing in terms of health in general. I mean, because these are more specific and these are generic, encompassing. And these, in the end, also, if you think of health, of quality of life as a generic construct, so there is you might potentially, as if you were playing Trivial Pursuit, take out one of these triangles and call that a health. Well, that would be the health-related quality of life. And these, of course, shaped by characteristics of the individual, but also characteristics of the environment. We did an iteration of this because we realized a number of things. First, that the symptom status could be, using the classical definition of WHO, we'll try to see how that would fit. And so, certainly for general health perceptions and functional status, you would have physical, psychological, and social symptom status. Social didn't make sense. Also, we realized that symptom status sometimes can jump over functional status in the sense that it may not impact in any way what you do or can or cannot do, and still, it may still have an impact in how you perceive your health, your symptoms. We also recognize the characteristics of the individual. One part of it was the psychological status, obviously, and we use our psychological status. We use these are our machinery for actually giving a prompt, eliciting a response, and making appraisals. So there's a bit of a feedback loop between these things. And also, lastly, that there is a gradient from the most objective to the most subjective. So you can ask in relation to, let's imagine symptoms, no? For instance, a frequency, which is more, at least is more, perhaps more objectable than intensity, or how much bother or how satisfied you are. So it is not that just because you elicit something from the individual, they have all the same, if you want, degree of subjectiveness. There are ones that would be more subjective than others. So yeah, okay, that's all very nice, but we're in the business of saving lives and improving health, and does it really matter, all these prompts? Well, first of all, prompts capture essential information that cannot be collected by alternative means. So if we believe that patient-centeredness is a reasonable thing to take into account, surely knowing what people who are the receiving end think about their health makes sense to a degree. And if there is no other way of capturing this, that would be an argument. Prompts can support patient-centered and shared decision-making. There is evidence that they can enhance patient engagement. I mean, if you use that, I don't have, I mean, in the interest of time, I'm not showing this, but in the UK, one of the efforts, I mean, in parallel to the PROMs program, actually just slightly before, in general practice, they started the quality and outcomes framework. And as part of that framework, there was an expectation that was basically pay for performance system in general practice. Pay for performance, meaning that you would provide financial incentives, more money to those clinicians' practices that would evidence better results based on specific quality indicators. Long story short, one of the indicators was the use of prompts for mental health, but specifically in depression and anxiety. And so what was very interesting is that I mean, perhaps later we can discuss how this was implemented, how much a disaster it was. But what was interesting was that the patients saw themselves validated. Basically, they went to see a doctor. They had a mental issue, and suddenly the doctor was asking very structured questions in relation to a mental issue. So they thought, oh, okay, so this is valid. I can have this problem, and they are recognizing this. So it can enhance patient engagement. It can help clarify patient priorities and improve communications about symptoms. We'll see that in a minute. It can identify gaps in care, can support monitoring outcomes in specific populations, benchmark providers, and track performance over time. It can be also used to, we're currently running a trial in Singapore, and we literally borrowing the idea, if not copying or stealing, borrowing from Denmark, in which it has been used for a number of years. They realized that they had so many routine visits in secondary care for epilepsy and for other neurological conditions. It was basically, you're okay? Yes, I'm okay. Okay, next. So they thought, can we not do it more efficiently? So basically what they do now, they trialed it, it worked well, and so that's standard practice now. They sent a prompt to the remotely to the individual, and based on the results, they said, look, you seem to be doing okay. There's no need to see you. We will be very happy to see you if you want, but if you're okay with it, let's check again in 6 months' time. And that has liberated a lot of time for actually seeing patients that would benefit more and speeding up queues. So there are many ways in which it can be used creatively. Benchmarking, we've mentioned, it's just for your information. In the UK, it's just to give you a bit of closure with that experience. It didn't work very well in the sense that, I mean, it made everybody work, collect that information, and they were expecting that they would be able to see over time the same hospitals lagging behind and be able to say, okay, here's where we have to intervene. And what they realized is actually that there was random variation. You could not predict only for any given year which one would be at the bottom of the league table. So not failed, I mean, but they were hoping to get something that they didn't get. What they got was actually evidence that all hospitals were performing reasonably similarly in terms of outcomes. So, I'm aware of the time, and I'm not started speaking about AI. So, okay, most briefly, disease models inform care models. Okay, so we come back to this later, but just in the interest of time, first model that was scientific, the infectious disease, one condition, one agent, one treatment, no, and a sequential model, diagnosis, treatment, follow up, off you go. Then with chronic disease, one condition, but multiple etiological agents and also multiple treatments. So rather than having a disease specialist, we have more a multidisciplinary team and a cycle model. No? So it's not you don't get released. And finally, with multimorbidity, what we have is multiple conditions, so to the power of n. No, whatever the previous one. So it's not just a multidisciplinary team. Now it's multidisciplinary teams in plural. So yeah, all the previous applies, but also we need to be explicit about goals. What do we want to get out of care? Trade-offs. We cannot just optimize everything, because if we optimize one, we impair the other one. And also realizing that we work in networks. So we need to organize care in a way that serves that purpose. And with this increased whole patient focus, because if you as you increase the complexity and the uncertainty, you always have a mandate to be patient-centric, but you could be more standardized, and perhaps here you need to be less standardized, and here you're probably the least standardized. So you need feedback from the patient, and that's where PROMs come into the role. So clinical decision making is one way in which you can use it. You can use them for screening people. You can use them for understanding whether they are responding to treatment. You can use them for quality assessment. So you would typically then not be using an individual interaction, but actually combining the results for, let's say, a group of people that you're seeing in your practice, and then comparing with others with the proper adjustments, everything else taken into account. And also you can use it to identify population needs. So if your population is not the one that, I mean, is the whole population in a given area or in a country, that's also an additional way of using it. This is a Cochrane that we did, in which we basically tried to assess the impact of using PROMs in clinical practice. Over 100 randomized controlled trials. This is basically what we saw, what was a sliding scale. So it improved, PROMs improved communication. PROMs improved that, I mean, and every step, because there is an effect, attenuation of the effect as you use it less in the immediate interface with the patient. So in the immediate communication, yes. Diagnosis, medium effect, I mean, people making their head around. We'll come back to treatment. Control of the condition, I mean, whether the condition is well controlled or not, another decrease, but still in between medium and small. Variation in terms of the functioning, and in quality of life, another peak. Perhaps the most striking difference was this one, no? That the doctors didn't change treatments based on the PROMs. I think it's mostly due to the fact that it's not part of clinical practice guidelines. There's nothing that says if a patient has a PROM in this score or here to this or to that. So they can make it part of the picture, but then when we have to make the decision, there's nothing to guide it. So that's an interpretation. Quality of life. I think this is because typically there has been this notion that you take it from the patient, you give it to the doctor, and then the doctor is responsible for all this. But typically, you can also give this information, feed it back to the patient. And even if you don't feed it back, they've been through the process of trying to think about these issues. And our hypothesis is that patients also they see it perhaps as it has an impact. I mean, measuring has an impact on the individual itself. I mean, in terms of, I won't go as far as to say the change of behaviors because we weren't able to measure any of that. Not that is not possible. It's just that it was well beyond. I was telling you 100 randomized control trials. It took us 3 years, and I don't think we will update it anytime soon. But this is the picture that we got. We did the same during a real synthesis, and we were also discussing geriatrics here previously, and I think that's also for you to help you understand that PROMs have been thought of mostly in the red part using a biomedical model. So thinking of them more as a metric like you would like a blood test. No? So you think in terms of clinical management with a disease focus. So you measure something, and then you would typically use the standardized PROMs. EQ5D, the SF36, the PHQ9. But if you come from the perspective, from psychosocial model, the perspective of patient-centered care, and you're interested in a whole person approach, and perhaps can we use them for goal setting, you will end up then using individualized PROMs, which are a completely different beast. And I was mentioning to geriatrics because in geriatrics they have been some of the individualized tools, the patient-generated index and SQL have been used for making decisions. And of course, I mean, it's not either or. I mean, ideally, there should be an integration. Okay, I need to be. Sorry, I will tell you more about this at some other point because we mentioned AI and we need to talk about AI. AI, I mean, it can go like this or it can go like the Terminator. Most people are very convinced that it will be like this. I don't think I can rule out the Terminator side of things. I wish I could. But what is very clear is that we are approaching, I mean, that this is a complete change of scenario, what we are seeing here. I use this picture because this is a 18th century steam powered ship towing away I think it was a frigate, I mean, a big ship from the British Empire about to be dismantled in the shipyard. And this is basically, I think, that conveys a bit, and also not perhaps unsurprisingly when the sun is setting, is rising, not very clear. So it's a major disruption on health systems. It combines all these three disruptions. So if you think in terms of the printing press and the internet, which was knowledge dissemination, suddenly you had access to information that it would take you, I mean, that if possible, would take you a long time to get hold of. And it was now at your fingertips. Well, now it's distilled and hierarchized and prioritized and even faster, because somebody is doing it for you. So think also of the Industrial Revolution, no? I mean, the role of humans in production, that's also changing quite dramatically with artificial intelligence, no? So that also is, I mean, you know, the Luddites, and I'm sure we will start to see Luddites again. Perhaps some of us will turn into Luddites in response to this, no? Certainly, the role of humans in healthcare production will change. But also, I mean, I think in terms of theory and models, and because it allows to crunch an amazing number of data. So it's just that it's very likely that we will be able to predict course of diseases and conditions a lot better than we currently do. So also in terms of our understanding of medicine itself may change. So then if any of those, I mean, all of them in isolation are huge to imagine, no? What they can be together. I used to start my introduction to family medicine with this, just to help students think about what is family medicine and try to identify what setting, what the individual is doing, who are they treating, etc., etc. And then, I mean, they often struggle because maybe it's because it's Singapore, but I don't know. It's too remote from them. We were writing this a vision for primary care in the 21st century for the Astana Declaration. We didn't mention artificial intelligence, so I think that for us, we're in a similar situation like my students when they see the picture and they cannot make sense of it. So it really begs for taking the time to appraise that is a seismic change and that we need to seriously consider how it will affect every aspect of our activity. I'll be very brief with how this I can see this impacting the three core aspects that I mentioned of family medicine: whole person, life course, and community. So I think we will be a lot better able to have patient-oriented integration of discrete sets of actions into individualized care and monitoring plans. So through the help of artificial intelligence, something that was very difficult, which is combining the different clinical practice guidelines, disparate, and also in the interaction, digested for the benefit of the individual and coming up with plans, and also using those clinical practice guidelines also to help develop these individualized care and monitoring plans. I think that will be the biggest revolution in whole person care. For life course, we will be able to predict long and mid-term, I mean in terms of time. Okay, let me say first, ability to predict and interpret health states and events based on individualized data. I make the distinction between prediction and interpretation, prediction long and mid-term, and interpret shorter and medium, because with the ability of data, we may be able to understand that some changes actually mean something, not they don't just predict. What we wouldn't be seeing is the first stages of something in development. That's why I mean trying to separate predict and interpret. And that's also that's something that AI will help us achieve. And in terms of integration of AI in the community, I was in practice in Shanghai, accrediting them on behalf of Wonka, and they were doing already stuff with avatars in which the doctors train their avatars to interact with patients, so that they would give. I mean, it's just for the period that they would be sleeping. So I mean, it's not just replacing the human with a machine. It's also acknowledging that there may be opportunities for people to benefit from those interactions. And so, and these avatars will be trained with the individual professional voice, style, and even will be given specific information, written information by the doctors themselves, so that there will be continuity in terms of the, so that it would be recognizable as their doctor for the patient. So the ways in which we interact with patients, the ways in which we are able to identify social epidemiological trends in the immediate environment. I mean, we may be able to detect epidemics a lot more quickly, and also enhancing opportunities for family orientation, which is a particular pet interest of mine. I cannot elaborate now. I will be quick. So first contact. How will we change? Digital first by default. Simultaneously optimizing standardization and individualization. Yes, both things can be achieved, because it would be feasible to be able to offer more consistent access, and at the same time, I mean, consistency in access, which one people are there can be tailored to the individual with digital first. Coordination, enhance the ability to support interaction, information exchange, and support decision making involving multiple providers. At present, it is a mess. You send someone you have to interact with the pulmonologist, and they also have a problem with the rheumatologist, and there is no clear way. I mean, you're back and forth and then to them, but they didn't address the medication that interacts. Now you need to go back again. With artificial intelligence, there may be approaches that facilitate a more seamless integration. I think that would be one of the biggest. One of my fears was that specialists will, particularly in environments that are very specialist oriented, that value so much individual choice and do not help people understand the benefits of actually seeing your regular doctor, and rather prioritize, I have a headache, I want to see my neurologist, even if they didn't have one in the first place. My biggest fear was that this would be basically that would help specialists increase their outreach. I was recently in Hong Kong, and the technical university, they're opening a medical school, and their interest is to create AI-enhanced family physicians. So, and this is a very welcome development, but I'm always using it as an example that I think perhaps that fear was misplaced. I mean, because actually the values that you will have now as a family physician increase tremendously your ability to deal with more, with information, with cases that may be less frequent for you, but with direct access to information and management approaches that make it feasible. So you can be a family physician steroids. I think that you can take care of many of a broader scope of activity. And continuity, well, with AI, electronic healthcare records, expanded interfaces. I mean, it can become, I'm sure, I mean, one of my interests is how the extension of the abilities to interact with individuals can make things actually more difficult. The same patient can, if some patients reach you out by WhatsApp and the other via email, and you have a call, and I don't receive letters, but maybe somebody would also decide to send me a letter, or they come to the, it's not so easy. I mean, when you have one mode of interaction, it's a lot easier than if you suddenly have to keep changing the racket tool because it came as an email and the other one comes on WhatsApp. So hopefully with this may help us dealing with this diversity. Proms and PROMs, we will be able to measure them with natural language. And that's actually literally what we're trying to do now in Singapore. So rather than to use instruments, standardized instruments, what we are hoping is that we will be able to ask you, how are you doing? You respond in your own terms, in your own language. You don't have to select very rarely in relation to how much pain do you have one. So you basically respond how you're feeling. And there will be the AI model will be able to give a score for that. And that's exactly what we are trying to do now. We are at the early stages, but I think it will be certainly, I mean, is a goal that is achievable. Improved empathy. That's very worrisome, but I mean, there's evidence that the AI models are perceived as more empathetic than humans.
Well, they're very agreeable, but they're not empathetic.
They are perceived as empathetic. I may agree with you, but okay, let's try to make the most of it. Okay, so then rather than being defensive necessarily about it, okay, if they can be perceived as is there a way in which we can use it to our advantage? But I mean, it may require fine-tuning and ensuring, like these people in Shanghai were doing, trying to align it so that it's more like your doctor than rather an average model. Hexi collection of scale, I'll have to save it for some other time. In 20 seconds, we are collecting information on patient experience for different conditions through in-depth narrative research. And we transform that into a website that includes, for people who say we're just diagnosed with diabetes and have no idea what it is, they can go there and find other people with diabetes who are explaining how they were diagnosed, what were eventually the complications, whether they need to be hospitalized, how they did for manage their food, their exercise, etc. We have evidence that this model, originally developed in Oxford, is used by patients, is used by practitioners to be trained on patient-centeredness, and is also used by policymakers to have a pulse to have a finger on the pulse of the patient experience as a whole in relation to the system. The implications for medical education, I think I'm in the last two slides. We will need doctors who can practice medicine focusing on outcomes rather than outputs. So rather than thinking in terms of the, perhaps this is more clear for those who operate in systems in which we have a number of targets, particularly for specialists also. I really think, okay, they need to get this done or get this other thing done. And we too sometimes think are obfuscated because of the pressures and so on. We need to make sure that they get this done. Well, let's focus on what we want to achieve rather than what needs to be done. The doctors who can practice focusing on care pathways as the backbone of consultation, room interaction along a continuum. What do I mean by that? That the consultation room model will be less and less and less and less the default interaction. I mean, the virtual will become the virtual, the offline, the asynchronic exchange, also the synchronic but virtual, would be more part of the default assumption. So we cannot think in terms of the consultation room. I was this last week with the registrars, and for the OSCE, one of them was asked to pretend that they were receiving a Zoom call, and they were put on a bit uncertain how to approach this. Well, it's likely that it will be increasingly the case.
So the interesting data, sorry, I've got to leave it to some. I'll just make this comment before I leave. I'm sorry.
Please.
The interesting data coming out of the private sector around remote consultations in South Africa is that we've dropped from around 30% post-COVID down to like 6%. So the public in South Africa, at least in the private sector, we would have thought people have more access to internet, more access to remote consultation, more demanding kind of work schedules, or might not want to step out of work. The usage of remote consultations has gone down over the last 3 years. So that's quite an interesting phenomenon. We don't know the reasons.
Yes.
Many of the funders have been prioritizing telehealth because it cuts down costs quite dramatically. But they haven't seen, even though they've promoted telehealth quite aggressively, the funders, they haven't seen the users picking up on it. So it's quite an interesting phenomenon. And the evidence in South Africa, at least, from the kind of the upwardly mobile part of our population, that indicates that maybe we're not headed in that direction.
I think there's probably also a generational aspect to it. So in the sense that the younger generations may be even demanding it increasingly, whereas those who are not as young anymore, like me, may have default expectations what it is to engage with the healthcare system, what is quality in the healthcare system. Thank you for that comment. I'll be brief with this. So rooted in data and behavioral sciences, so that what they will need to learn, of course, they need to learn medicine, these future doctors, but they also need to know behavioral sciences in particular, because the interactive aspect will be one of the strongest, and also what data mean, because to be aware of the limitations of data themselves, because the artificial intelligence may make inference based on specific data, and they need to know what the data may actually mean and what may be the inherent biases or strength of those data. So they need to know more about the data.
So time check. I think I'm aware that there's another activity starting now.
I'm already. I've run out of time. I'm sorry. I'm really sorry. So critical thinking and maximizing their own added value. And one thing is, someday, I mean, we were all in the other building, and then an alarm went off, and people were left without their computers. So someday the systems will not work, and people cannot say, "Oh, now what?" So they need to be able to operate in both environments. Thank you, and apologies for completely overrunning. Thank you.
I don't know if there is time for anyone who wants to maybe has maybe one or two quick comments or questions. I just wanted to also say, as a bit of an advertisement, that we are planning a workshop on coming Monday, which we'll also share more details soon. But maybe if there's one remark, one reflection or comment, something that yes, please.
Just a comment when we're sharing about how people would be able to express how they're feeling, and then the AI will code that. So is there a way of saying that AI will now know better than us and be able to code what that means for humanity? So, it's almost like AI is now being able to code us instead of us coding AI.
It's very interesting, because in the development, I'm talking to sometimes it's, you're not sure how big is the divide, or whether it's just a linguistic sometimes divide or other sorts of divide. The people who are helping, who come specifically from computer science, they see absolutely no problem with just letting the AI run loose and guess what is your score. And I'm saying, no, you need to have data in which people provide the narratives and the scores separately. And this is no, but the AI can figure it out.
Yeah, but it's worrying because if AI doesn't have the nuances as well.
Of course, yeah.
So, thanks, Shema. I think that's been fabulous. But one of the areas that I think maybe you glossed over was the issue of equity.
Uh-huh.
And I think when we look at what's happening within low and middle income countries, AI does have the potential to reduce the inequity that exists within the health services. So, yes, I think your slide of Terminator versus the sort of Nirvana on the left is very apt. But there's a lot of good that can come out of it, because where we have no services, the question is, how can AI, and I'm looking at it from a geriatrics perspective.
I'm taking notes, eh? I'm not checking my phone.
No, that's fine. Where AI comes from, particularly in geriatrics, where we have lack of skills, lack of time, lack of all the lacks of things. People can't access services, they can't get out of their homes because they're disabled because of many reasons. It can allow for scaling up of services into areas where people were previously not getting services. You speak about care planning. I've been using AI quite extensively now, using very good assessment instruments, and it's giving me better care planning models and care planning programs. And then any human I've seen, and repeat, these are people, my own experience of 25, 30 years of doing care planning, putting together multidisciplinary teams of occupational therapists, physios, nursing practitioners, pharmacists, doctors. It generates a better care plan than most of that. And then can be, and yes, sometimes it doesn't synthesize it and gives you a whole list of 10 things which you can't care plan for, because, as you said, there's a trade-off that you're going to do when you're trying to do one thing good and another thing does fall by the wayside. But at least as a team, you can, and then with the person themselves, they can sit around. It also does empower the individual, because when they walk into a facility or they wheeled into a facility where the healthcare professional tends to say, I've only got 2 minutes to see you and I want to just take your blood pressure, the person can turn around and say, but hang on, I've done this. The most important thing for me is the fact that actually I'm short of breath when I'm in bed at night, and I think it may be my heart, because or I'm peeing 3 times at night and I'm not sleeping well, and you're only worried about my blood pressure. It could empower. So I think we need to start considering all those outcome measures that are so positive over there. So I just, yeah.
Thank you. I really appreciate it. Thank you. Excellent comment.
Just in terms of medical education, I mean, are you seeing that students are running ahead of educators often in using AI tools? A generation that has grown up with AI is going to see no problem using it, and educators are increasingly scrambling to catch up, aren't they?
I think that the main problem is actually whether they actually learn anything. That's the problem, because you can get away with that by using AI and but then you need some form of scaffolding, because I said one day the black is off, and then you cannot be completely naked in the dark. You need to have skills and concepts and principles, things that can guide you in that darkness, and or even, I mean, we all have the experience of the AI hallucinating, and of course, it doesn't mean that these will not be managed, but well, maybe the data that is using at that particular time is not good, and you need to have a sense of being able to get at that. So you need to be trained. You cannot just get away with using AI for everything. You need to grow as a professional.
No, we understand that, but your students don't always.
Yeah, of course. Yes.
Thank you.